evening, ladies and gentlemen. I call the meeting to order. Please stand for the national anthem.
Sri Lanka Mata, Upper Sri Lanka, Namo, 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 Namo Mata. Sundara Siri Barini, Surandi Ati Somarwana Lanka. Ranya Nalaya Nikamal Vala Turupi Jaya Bhumiya Ramya. Appa Hatta Sapa Siri Sata Sadhana, Jeevana Ye Mata. Viliganu Mena Appa Bhakti Puja, Namo Namo Mata. Upper Sri Lanka, Namo, 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 Namo Mata. Upave Apavidya, Upamaya Apasatya, Upave Apashakti, Apahagatulla Bhakti, Uparapa Aloke, Apade Anuprani, Uparapa Jeevanade, Apamuktiya Ubade, Nava Jeevanadini, Nitila Apakubudu Karan Mata. Jnana Veeda Vadavamina Ragila Yanu Mela Jaya Bhumikara. Ekka Mamata Devaru Kalavadina, Yamu Yamu Vinopama. Prema Vada Samadena Durala, Namo Namo Mata. Upper Sri Lanka, Namo Namo, Namo Namo Mata.
Very good evening, ladies and gentlemen. I welcome you all to this our usual CPD activity. And we have been very active actually this year also, and we have already set up for next few months also. And as usual, we have a lineup of eminent speakers who will address us and sort of will share their expertise on the particular subjects which they are going to deal with. We have two very relevant themes. One is on current update on influenza vaccine, and the other one is a management of goiter. So both these things are really relevant for us who are working at the level of primary care. And I think probably we will learn a lot and then get our benefit for the patients for them to sort of have the best of the current expertise. First, we'll be dealing with the current update on influenza vaccine by none other than Dr. H.D. Wickramasinghe, MBBS, MD, DC, CCP, and Senior Consultant Pediatrician. Of course, he needs no introduction. He has been one of our very popular and, of course, very eminent speakers for IMPA. And, of course, he is currently the President of Vaccine and Infectious Diseases Forum of Sri Lanka. And also to my personal knowledge, I think he was one of the very first people who dealt with the logistics of Covishield, and then was informing the government about the Serum Institute, their help and all. Everything was sort of planned behind the scenes. So thank you for that, Dr. Vikram Singh. And of course, he is a past president of the College of Pediatricians, and then he's a well-respected vaccine expert in the Southeast Asia region and South Asia Pacific region. And of course, he's a very well-known senior consultant pediatrician. May I call upon you, sir, now to address the audience?
Thank you very much, Mr. President, for your kind introduction. Good evening, everybody. My talk today is actually an update on influenza and influenza vaccines. If I have time, I'll just discuss a little bit about why influenza is so important at the time of COVID-19. Right, it's a bird's eye view of my presentation. I'll just discuss a little bit about history of influenza, the virus itself, epidemiology, clinical features, and the vaccines again, the history of vaccines, the type of vaccines, and why should we vaccinate, who should get the vaccine, and safety, efficacy, and other issues, and just the key messages. Right, history of influenza, the first influenza pandemic, it must have been there before, but people did not know. But probably the first recorded one was in 1580. But and then there was a known flu epidemic. This is again unknown, but people believe that it was, it's not working. Right. So this is Spanish flu. Before that, I think the known flu, this was a known flu pandemic was in 1899-90, which is called Asiatic Russian flu. Mortality rates said to be 0.751 death per 1,000, possibly H2N2, people don't know. Then 1900, there was again possible H3N8, but the most important was 1918 to 1920, the Spanish flu. 500 million contracted and at least 20 to 50 million. Nobody knows how many people died because the deaths were so much. And they believe it is ranging from 20 to 50 million died of H1N1. And this was very interesting because that most of these specimens have been kept. And when they investigated their lung tissues now, they found that most majority of these people who died, they did not die of influenza. They died of pneumonia due to bacterial pneumonia. So this is the point I wanted to see, that therefore, most of these people who die, particularly elderly people who die of influenza, after contracting influenza, they die because of secondary bacterial infections. This is a very classic example that which was there, very evident in the history. And then 57, 58, there was again H2N2, then again 18 to 6, and then there were a lot of, and the last pandemic was in 2009. Now this is again this is about Spanish flu, and you can see those deaths. But the importance I want to tell you is that even those days people knew that wearing mask is actually protect them, particularly the people who were healthcare workers. So that concept has been there for a long, long time. And now this is the structure of influenza virus, which is very important for us to know because it has particularly the so-called, there are three types primarily, which is called the influenza A, influenza B, and influenza C. And influenza C actually it's not very relevant because it does not cause a serious illness. Influenza A and B is important because A is the one which is very important because they have spike proteins like COVID-19. And there are two very important spikes that is called neuraminidase spike protein and the hemagglutinin spike protein. And that is why they were labeled as H and N. H is hemagglutinin, N is neuraminidase. And why it is important? Because this particular protein, the surface protein, they have H1 and 18. The 18 types are there for hemagglutinin, and there are 11 types for neuraminidase. And whereas for influenza B, you don't have that. You have HA, and then only then there are two varieties called Yamagata strain and the Victoria strain, and they don't have anything more than that. Why it is important for us to know is that because you have so many surface proteins, you can sort of you can sometimes you can get the same virus after some time in the population. You can get H1 can be converted into H2. Genetic mutations can take place, and you can get various combinations. So these so many combinations are available with influenza A. So therefore, that it is very difficult to find a vaccine for it, a definite vaccine, because each year it is constantly changing. Whereas for influenza B, that is not the case because there are only two, and they may vary from one to other, but nothing very much. So therefore, influenza B generally present as not really pandemic, so endemic, but this is sporadic. It's there in the community. Occasional epidemics are there with this. Whereas in influenza A, you get epidemics, you get pandemics, and you can get sporadic cases also. Right, and that is what they call in the West Coast seasonal influenza. Right. Now A, as I told you, causes outbreaks most years and are the usual cause of epidemics. Live and multiply in wildfowl from where they can be transmitted to humans. Actually, not only wildfowl, any avian is the commonest, and also swine is also there. Also carried by other members, particularly swines. Then B virus tend to cause less severe disease and small outbreaks, predominantly found in humans, and also this affects mainly burden of disease mostly in children. It can occasionally cause pneumonia, but it generally doesn't cause that much of deaths. Now, this is what I really want to tell you, that this is orthomixoid group, and A, B, C. A, as I told you, there are 16 hemoglobin proteins and 9 NA proteins, so that they combine each other. You can see that this is just an example. If you have H1, H2, and N1, N2, you can get 4 variants. So you can imagine with this combination how many variants you can have. So influenza A and B causes seasonal epidemic. C mainly causes mild respiratory tract infections, which is not relevant to us. Actually, influenza A is divided to subtypes based on the amount of what is the H protein and the N protein. So you have H and N types. These are the influenza virus that we are talking about. They can switch. That is called actually resorting, and that you can get you can resort among themselves, or you can return among the other animal influenza viruses, which I will discuss. Now, this is called the antigenic drift and antigenic shift. It's very important for us to understand what this is. Antigenic drift is that it's just that you have the same thing, but there are just mutations among those proteins. So that get mutated while they are really disseminating the disease from person to person. So antigenic drift suddenly becomes patient, but the organism can be virulent and you can get epidemics. Or you can get even pandemics. But it's not what is very important for us because most of the pandemics are caused by this antigenic shift. Antigenic shift, what happens is there are three primary types of, it can happen in any, it could be there in any mammal, but most of these cases are avian influenza and swine influenza viruses. So just graphically, if you really wanted to show, this is exactly what happens. And the drift is actually a genetic mutation, and you just take it, one gene becomes different, and you just call, and it can be either highly virulent or not virulent. So depending on the virulence, you can get this. Antigenic shift is pretty different. Antigenic shift is you have, now for example, you have human influenza, you have avian influenza, you have swine influenza. When they really resort to each other, sometimes you might get a novel virus. We carry genes from the avian as well as from the swine. So you what is the gene which has come from swine or avian? You have given avian influenza epidemics, you carry swine flu, and various names have been given. So because of the complex nature of this influenza virus, unlike other viruses, it is very difficult unless you really monitor the epidemiology every day, every year. Then we would know what are the type of influenza hanging around in the community. So for this, so this is again the same thing, just to explain to you, avian virus and the human virus gets into the swine, then you get the new resorted virus, and then from that the human being get it. So then we call it the swine flu. But you get it from that. So this can happen this way as well. So you give different names. You need not have all three combinations, you can have two combined together. Now these are in the history, what are the things that has happened. You see in 1918, which now we know is H1N1, then H2N2, H3N3, H1N1, H5N1, H9N2, H1N, and various types. And the last one was in 2009 pandemic. Right. So as you can see, that this is not the end of the game, because that these mutations can go on happening. And you can get new variants from other animals. So therefore, influenza pandemics are unpredictable. And also we don't know, it can happen anytime and can wipe out just like what they did in 1980. That could happen. Because we just don't know. And also remember that the vaccine available today may not work for that particular epidemic. And in front of this, this 1918 one is very interesting, because in 1918, when the first wave went off, and there were very little deaths, and the people were not very worried about it. And then what happened was the second wave came about 7 to 8 months later, which lasted till 1920, and that was the wave which really killed people. So that is why we expected that COVID also can happen the same thing, because the same mutations can take place because they are mRNA viruses. Anyway. Now this is just an example. And in this actually in the 2009 epidemic started in Mexico and in US. And then by 27th of April, they declared the global pandemic, because started spreading to Europe, and then started Europe and all over. And then you can see by 2000, a year later, not even a year, less than a year later, you can see that it has gone all over the world. So this is that is because in the modern days now, say in 2000, when 1918 epidemic came, it took a long time to go spread, but now of course it can happen. Like now you see COVID spread all over the world in no time because of the global travel. And for example, there was another epidemic in 15, I cannot remember exactly the year, which was actually this plague. And that's called Black Death. And the plague, of course, took about 7 to 8 years to spread around the world. So because that time that we didn't have, there was not much of global travel. Now, clinical features of influenza, actually, I need not to tell you because this is spread from large droplets, same with COVID, small particle aerosols, and by hand to mouth, eye contamination, exactly the way that the COVID-19 spreads. And again, just like in COVID, people with mild or no symptoms can still infect others. Now, in COVID-19, the important thing is that if you are in the first 5 days of you don't have symptoms, and before symptoms, first 5 days before symptoms, you are highly infectious. So much so 44% of infection takes place before you get symptoms. This is why COVID-19 we cannot prevent because the person who gives to others doesn't know that he is having COVID. And this one also, this doesn't have that much, but it also sometimes you can meet people who are asymptomatic, but you don't have a prodromal or the before symptoms you are not infected. But the important point is those people who are asymptomatic also be highly infectious. Incubation period is 1 to 5 days, average 2 to 3 days, it may be longer sometimes. And the common symptoms, of course, fever, chills, headache, muscle and joint pains and extreme fatigues, cough, sore throat, and stuffy nose. And sometimes they can get gastrointestinal symptoms, vomiting and loose motions. But what is important is the neural complications. You can get febrile convulsions. Actually, majority of these people can present, children can present with febrile convulsions. Reye syndrome, meningitis, encephalitis, transverse myelitis, Guillain-Barré syndrome, cardiac problems, pericarditis, myocarditis. Then respiratory problems, or the otitis media, croup, then sinusitis, bronchitis, pneumonia, either viral or secondary. I put viral and secondary because secondary pneumonia is very common. And exacerbations of chronic lung disease. So people with chronic lung disease is very dangerous. Then pregnancy also, because I think that we should discuss really these issues. Increase maternal complications, increase infant perinatal mortality, increase risk of prematurity, smaller neonatal size and low birth weight. Then you can get myositis and rhabdomyolysis. And those are the things that you can get as complications. So it's not as mild as you think. Now, this is seasonal influenza. This actually is from this is seasonal influenza. You can see this is actually the 0 to 4 years of age. This is actually 5 to 17 years of age. This is actually the season. You can see this happens actually in the first December to March, that is winter. Not winter actually, this is December to March, this is just and during the winter period, you can see that febrile seizures reported 6 to 20% in children, and intensive care required by 4 to 11%. 18% were children under 4 years actually. And out of that, 27% was children less than 6 months. And then the other important thing is that there is 15, 17 years, not very much, but it is there. But the important point I wanted to make is that, this is about the seasonal influenza distribution. It's in other words, it is common among very young children, 0 to 4. But what is important is the depth and the complications. Though you don't have many people, adults getting it, but those who get, the chance of dying or chance of getting complications are much higher after 65 years of age. So this group is at a risk of getting influenza, though they don't have as much as children between 0 to 4. Now, this is again to distinguish, this is, as I told you just now, now see the highest incidence of influenza is in children between 0 to 4 and it goes down and then over 65. But this is the number of high risk of complications. Complications are very high in the adult age group, the old age group. So elderly are the most people, influenza patients at risk, actually elderly people and pregnant mothers. Because they are at risk, because not that they are going to get it, but if they get it, chances of dying is pretty high. Now this is actually 2009 influenza epidemic, the pandemic. In the pandemic in the EU, it's very surprisingly, the highest incidence was between 10 to 29. Because that is the mobile people who walk up and about. So that, even they are domestic, this is the domestic infection, not travel related. But still you can see the highest incidence is here. Now I'll show you that particular slide. So you can see highest incidence, this is in the first 4 years, not that much, but it is there. But the highest incidences are here, and it slowly comes down. But you see the mortality should take, now see the mortality has come down up there, and then it goes up in the 20 to 29 age group, and also complications, and also when it comes to old age, there's a dramatic, remember, the number of patients who have got influenza is very little, but the number of patients who die proportionately is much higher in this age group. So what I really wanted to say is whether you have seasonal influenza or you have epidemic or pandemic influenza, the majority of the people who are going to die or majority of the people who are going to have complications in this age group, proportionately. Now this is just a little bit of vaccines. Historically, the first vaccine was actually a whole virus vaccine. It's the first generation in a kill vaccine. Then the second generation vaccine came, what we call split vaccine. They took only parts of the virus particle. And now we are using only the third generation called sub-unit vaccines, where you take the N and the H proteins, spike proteins, and you make vaccines. And this is very interesting because after 1976, before that, by 1950, we knew that people knew that the virus is changing every year. So they did not know what to do. So now we know because we are having sub-unit vaccines. So there are places in the world they collect data and they know what vaccine to be included this year. And they put those genes with it, those spike proteins. So they make the vaccines accordingly. Now this is where therefore WHO decided in 1952 itself, because when they came to know that the vaccine is changing every year, they decided to have established network all over the globe, stations to do studies, influenza studies. So currently WHO has 128 institutions and in 99 countries. In India they have 4, and all these countries they have various numbers. So they are doing collecting data and these centers. Then the objective is actually the surveillance enables recommended twice the content of influenza vaccine for the season. So they will go on collecting the data, A as well as B. And then also it serves as a global alert mechanism. If suddenly you have to see in a particular village, particular country, a new variant coming up, say swine influenza, they know before it comes because the centers are there working, but unfortunately, it is there only in 99 countries. It's not there in all the countries. So it can still happen, but there is a global alert mechanism. So that as soon as there is a variant coming up, before it really causes pandemic, people would know. Now, this is another interesting slide, that this is the equator. We are just above the equator, right? So this is the equator. So they divide into zones. This is WHO zones. But difficult to make vaccines to every zone. So therefore, what they do is they divide the world into two: the northern hemisphere and the southern hemisphere. And they give the vaccines according to this. So what they do is all these centers below the equator, and whatever the studies that they do, they collect the data, WHO collect the data, and they find the most important two influenza A present in this region. So they make the virus, the vaccine out of those two viruses. Similarly, the northern hemisphere, they do all these vaccines they collected, the viruses they collected in these centers, they analyze them, and then they select what is the most appropriate combination of H1N1, H1N, H and N to this particular northern hemisphere. So you have two vaccines called southern hemisphere and northern hemisphere. But if you see very carefully, we were just little above this equator. So theoretically, we should get northern hemisphere vaccines. But we are getting actually southern hemisphere because the studies have shown it's very sad because the India is getting northern hemisphere vaccine. But we were put into this category, the equatorial Asia, but we are really getting the so there are a lot of studies now going on in the world. They might come out one day that the tropical belt will need a different strains for two reasons. A, that this part, the southern hemisphere part, and also northern hemisphere, they have winter, they have seasonal influenza. So the vaccine is made for that season. So we don't have seasons, this tropical belt. So tropical belt, we need a separate vaccine. But unfortunately, we are actually in Apache. Apache is Asia Pacific. Apache Asia Pacific. What is it? Apache is Asia Pacific. Something on control of influenza. And we were discussing, actually, we had one meeting and they were discussing on that. And unfortunately, majority of the people from Apache is from this region. Philippines and Indonesia, Australia, and they really were quite happy with their vaccine. So that actually we have to, not Asia Pacific, we have to shift to the tropics, suppose. If you really wanted to have together with India. Right. So this is very important for us to know because neither southern vaccine nor the northern vaccine suits us. So we don't know, we give the vaccine, but we don't know how effective the vaccine is going to be to our people. Now, this is just to show you that in 2021, this is the WHO recommended. If you are making egg-based vaccine, quadrivalent vaccine, these are the lineages you take. If you are making cell or recombined vaccine, this is what you are going to make. And then if you are going to make a trivalent vaccine, this is the combination. And this is cell or recombinant based vaccines. This is what we should use. That is this. So every year they do that. How do they do it? This is how they do it. They collect all the data in mid-February. They get all the data. So you have a WHO meeting, And in the meeting, they go through all these things and they find what are the really the viruses that we should take for southern hemisphere and the northern hemisphere. Then they go on doing this thing, and by the time they get the approval, it's going to be June, and they get the license approval, then they start manufacturing, and by August they distribute, and by October you give the vaccine. So this process going on every country, northern hemisphere as well as southern hemisphere. That is how it is being done. Now, these are the way how you can make vaccine. This is particularly so with COVID-19 too. You can have inactivated vaccines, you have killed vaccines. You can have live attenuated vaccines. They are live, they are replicating, they are multiplying inside you. But they are attenuated, so therefore they don't cause disease. Then you have subunit vaccines. You take the H and N particles, genetic proteins, and you make the protein combination. These are called actually in COVID-19, they are called protein vaccines. You take those proteins and you make the vaccine. This is what is being done actually mainly for two reasons. Because as I told you, you can get the ideal combination which is relevant for us, for that particular hemisphere. Then you have nucleic acid in research like the COVID-19, you know that we have the nucleic acid vaccines. The Moderna and Pfizer vaccines, they are RNA viruses vaccines. So similarly, you can make actually nucleic acid vaccines as well. Now this is the same thing actually, but this is how they do it. Majority method of production they use, initially they inoculate into the young embryos, chick embryos. And once they multiply, they can take it out and do cell culture. But generally they culture only in egg-based. And sometimes you start with egg-based, but then you go to the cell-based. So whether you make it egg-based or cell-based, there is a very little amount traced to egg proteins. But amount of egg protein is much higher if it is egg-based, very little if it is cell-based, because it's only the initial part of culture is done in the egg. Then you have recombinant one that is also now coming up, not available globally. And then you have live attenuated vaccines, a separate group actually. This is the live attenuated vaccine. Started with egg-based, then you make live attenuated vaccine. This is inactivated vaccines, and this is actually the recombinant vaccines. So flu vaccines are divided into three actually, primarily. One, you have inactivated ones. The second one, have live attenuated ones. Inactivated is actually you give by injection. Whereas live attenuated, you give by nasal application, because it is live. So it's just like you are getting influenza. None of the flu vaccines can cause clinical influenza in those that can be vaccinated. So therefore, even live attenuated there's no reports of getting real influenza. So then again you divide into two, trivalent and quadrivalent. Trivalent also you have live ones as well as inactivated, but now all the live attenuated vaccines are quadrivalent. We don't have trivalent live vaccine. We have only quadrivalent vaccine. The difference between the trivalent and quadrivalent is trivalent you use two subtypes of influenza A and one type of B. Whereas in quadrivalent you use two types of influenza A and both, I told you, B virus is only two, Jagamata and the Victoria. So they use both in quadrivalent vaccine. So as quadrivalent vaccines contain both lineages of B viruses, both lineages, and therefore may provide better protection against the circulating B strains than trivalent flu vaccines. So that is a very important point for you to know. Now, whether you give trivalent or quadrivalent, it doesn't matter as far as the influenza A is concerned, because both they have the WHO selected two strains. However, the quadrivalent has both A or B virus, both types are there. So therefore, if at all, if it is superior, that is superior in protecting influenza B only. Right? The live intranasal vaccine offered to children aged 2 years and over, actually they say 3 years now, and over, and it's a quadrivalent vaccine, as I told you. As in the inactivated vaccine recommended for children aged 3 years and above who cannot receive the live vaccine. So now the present recommendation globally for children over 3 years, over 2 years, to be given live attenuated vaccine. Why we will discuss. Okay? Now, live attenuated vaccine, it's a live vaccine. A live attenuated nasal spray is the recommended vaccine for the childhood flu programs. Globally, not in Sri Lanka. The live attenuated influenza vaccine has been shown to be more effective in children compared with inactivated influenza vaccine. Number two, it also offers some protection against strains not contained in the vaccine as well as to those that are or has the potential to offer better protection against virus strains that have undergone antigenic drift. So they have found that even if you have antigenic drift, sometimes this live vaccine, because it's a live vaccine, the live replicating vaccine, it has not only the HNA proteins, but it has others as well. So therefore, it provides a better immunity, and it may be provide immunity for other strains as well, which is not there in the vaccine. Third important thing is, since the vaccine is comprised of weakened whole live virus, it replicates inside the body as a natural infection, which induces better immunity, and also it induces mucosal immunity because we are going to give it nasally. So when you give the studies have shown that when you give the live attenuated virus, particularly during the seasons of when you have seasonal influenza, it protects others as well. So there is some form of herd immunity when you give live attenuated vaccine, which is not there with kill vaccine. Right? So in addition to being attenuated live virus, live have been adapted to cold so that they cannot replicate efficiently and body can, they cannot require. This is an important point actually. This is one of the reasons. Live attenuated actually, the body temperature cannot multiply so fast, so therefore actually it protects multiplying heavily inside the body. LAIV has a good safety profile in children aged 2 years and older. So actually this is probably the best vaccine to be given to children over 2 years up to about 65 years or 40. They say 49 years, 50 years. The recommendation now is up to 50 years. Why? Now you can see the key features. The vaccine type is actually, this is inactivated, this is live attenuated. You have 4 types. The inactivated one, you have either 3 or trivalent or quadrivalent. Approved age 6 months and above, this is 2 to 49 years. Right? Then admission, this intramuscular, this is very interesting because only few vaccines are being given intradermal. This is given intramuscular, though it is a vaccine, it's a viral vaccine, we give it because if it is a live vaccine, like whenever you are giving a live vaccine, like Japanese encephalitis, this is live attenuated vaccine. Then you should give it actually the subcutaneous. MMR, chickenpox, we give it subcutaneous, whereas this one, a kill vaccine, but this is given intramuscular. Whereas the live vaccine is given intranasal spray. Then when you have chronic diseases, this is what is important. If you are having asthma, if you are having serious illnesses, anything, lung illness, whatever it is, then you better not to give the live vaccine. You give only the chronic. If you have a chronic illness, you must give only the kill one, not the live one. Pregnancy, for example, you only give the killed one. Old age, you will only give the killed one. The contraindications in immunosuppressants, there is no contraindication. You can give the killed one, but the live one you cannot give. So in other words, the chronic illnesses, if you have, you cannot give live vaccine. If you have any contraindication, if you are immunocompromised, then you cannot give live vaccine. But this is what is important with the live vaccine. When you are given live vaccine, you can see hemoglobin response is not very much, but it is very much there with these two, because obviously because they are predominantly having the HNA. Here we are having other proteins as well, so the body has to produce antibodies against most of these other proteins there. But what is the most important? Nasal immunoglobulins are very high. So that mucosal immunity is there, so it protects the person as well as others from getting illness. And also this is another important thing, CD4 and CD8. Now they found there is what you call tissue resident lymphocytes. Very interesting phenomena. The tissue resident lymphocytes are there in the, it's actually memory cells. They are in your nasal cavity, they are in your mucous membrane. So whenever the virus gets into your body, you have immediate, they recognize immediately and produce antibodies then and there. This is not in the lymph nodes. Normally the memory cells are there in the lymph nodes, but the so-called tissue memory cells, resident memory cells are there in the tissues, mainly the epithelial cells. So they produce, those memory cells start producing antibodies, so therefore there is a very good response. This is important because COVID-19, there is a vaccine coming up, which is like research has been done in Washington University, and that vaccine also given intranasally, and that provides apparently mucosal immunity and protection from community infection as well. So it protects from community infection. Right. So effectiveness, this is the problem. You see that vaccine is not only efficacious 50 to 60% for adults between 18 to 65 and little less for very elderly. Because elderly, when you're taking up the vaccine is not, the immunity, building up immunity is not very good. People over 65, they have what you call immunosenescence. Immunosenescence, when you are after 65 for us, we don't have that much of immunity. Our product producing immunity is much less. This is why COVID-19 vaccine, people over 65 years of age, they don't have that much of reactions like the young age group people. It is because of senile, it's called immunosenescence. But with COVID-19, the beauty is that it takes a long time to build up the immunity, but at the end of the day, the immunity developed by the adults as well as these people over 65 is almost the same. Even though it starts slowly, because it starts very slowly, they don't have that much of reactions. Reactogenicity is much less. Now, that is one example to quote you. In 2014 and 2015, flu vaccine only provided limited protection against the infection as the main strain that circulated differed from the vaccine that they have selected. So the vaccine manufacturing WHO gave this particular combination, but actually the strains they were circulating was entirely different. So after that, for the last 10 years, generally it has been a good match. The WA match is quite reasonable, so there is almost always 50 to 60% of protection. You cannot expect 100% protection because that you don't know what strain or what combination of vectors cause the illness. So this is actually just to show you that we are now in Sri Lanka, we have quadrivalent vaccine and the trivalent vaccine. So this is the phase 3 randomized control trial in adults and elderly people, and this is the result. the conclusion is very interesting because the conclusion was the quadrivalent vaccine is non-inferior in immunity to trivalent. So that means both are equally the same, right? But it's superior to alternate lineage B strains than TIV. That is, in other words, it's better. Influenza B, there is a better effect, protective effect than trivalent. Obviously, because trivalent has only one beta B strain, whereas this one has two. Safety and tolerability profiles of both are equally the same. So the message I want to tell you that it doesn't matter whether it is trivalent or quadrivalent, as far as the influenza A is concerned, the protection is the same, but B perhaps better. Now this is again children. That was it for adults, this is for children. The same thing. Quadrivalent immunogenicity comparable to TIV4 shared lineage influenza strains and superior to TIV4 alternate lineage influenza B strains. So, I'm sorry, this has to be shared lineage A influenza strain. So, as far as the A strains are concerned, both are equally the same. As far as the B is concerned, they have probably better. So, the inclusion of second B strain lineage does not compromise safety. It's the same. Safety wise is the same. So this is a study done in US again to show you the same thing. Safety was similar between the two vaccine groups and the QI emergency superior over TI4 B strains. That's all. So both are sort of quite good. Now this is little different because this is ACIP recommendation and the NHS recommendation little different. So the recommendation is that you should give for children over age 6 months to any age. You should give the vaccine. That is in those countries. So, but even in those countries now, for example, in US, UK, it's only 30% of the people are getting the vaccine, influenza vaccine. People are frightened to get the influenza vaccine for many reasons because they think it doesn't work. Because every year you are changing and you have to get the vaccine every year. So very difficult to give like other vaccines to almost everybody. So there again, they also have categorized people that you should get the vaccine. Age 6 months to 4 years, as I told you, or seasonal influenza, almost 87% occurs in that age group. So they, even though they get less symptoms because you can prevent infection if you give these people. 6 months to 4 years. Over 2 years, you give the live attenuated vaccine, but less than 2 years, you give killed vaccine. And those people who are having problems, you don't give the live vaccine. Then chronic pulmonary, cardiovascular, renal, hepatic, cognitive, neurological, neuromuscular problems also, you should give the vaccine, particularly cerebral palsy. Hematological or metabolic disorder, including diabetes mellitus, you should get because they also can get complicated influenza. Immunocompromised people also you should give influenza the vaccine, but you must not give you must not give live attenuated vaccine. Receiving long-term aspirin therapy you should not give because I told you influenza, one of the complications of influenza is Rice syndrome. And so they found that if you are giving aspirin, particularly if you are going to give live vaccine, you should not give. If you are giving aspirin, you should not give the vaccine if at all. You can give inactivated vaccine. Resident of long-term care facilities and pregnant mothers. Pregnant mothers is very important. Now, why we should give vaccine in this risk group? Why? Because you can see this particular study. You can see that it is done in England, September to May. In risk group, actually 59% of people had actually fatal flu out of those people who died. 59% of them were having risk, but some risk factors. So people who did not have risk factors, they have only 40% deaths. But you see, if you take the mortality per 100,000 population, you can see not having any risk only 4%, but if you have risk, it is 10 times higher. So this really shows that if you have any disability, whatever this diabetes, including respiratory problem, heart disease, renal disease, neurological problem, the risk is always pretty high. So therefore, we should give the vaccine for these people with these problems. Now, pregnant women. Why it's very important? Because as I told you, in Sri Lanka in 2015, there were 17 deaths due to influenza, and they are all and majority there are only about 20 deaths or something. I can't remember exactly how much, but out of that, 17 were pregnant mothers, almost all. Deaths were due to pregnant mothers. So, pregnant mothers, it's very important to vaccinate. All pregnant women are recommended to receive the inactivated flu vaccine. You never give the live vaccine. Inactivated, irrespective of their stage of pregnancy. Remember this. Irrespective of their stage of pregnancy, whenever you see someone, you should give the vaccine if she is pregnant. Pregnant women can increase risk from complications if they contract flu. Having flu during pregnancy may be associated with premature birth and small size birth. Flu vaccination during pregnancy provides passive immunity against flu to infant in the first 6 months of life. Studies on safety of flu vaccine in pregnancy show that inactivated flu vaccine can be safely and effectively administered during any trimester of pregnancy. No study to date has demonstrated an increased risk of either maternal complications or adverse fetal outcome associated with inactivated flu vaccine. That is very important for you people when you are convinced the mother that we generally don't give vaccines, or we tend to avoid giving vaccine, but this one you must say that you have to get the vaccine. Remember that the vaccine has to be given every time she gets pregnant. Every time, because every year it's changing. Women should be offered the vaccine every time they are pregnant. Flu immunization should also be offered to, I'm sorry, my time is going, no, I don't know. Second speaker is here. Okay, I'm sorry. Flu should be offered actually people in the long residential care homes, and even if they are not told you, because that people who are in university halls, who are collectively living, collectively going to eat, that kind of people who, and also you should give for the carers. In an elderly homes, people who are caring, they also should get it. Then when you have an immunocompromised child in the person in the family, I think everybody in the family should get it. And then the healthcare and social care staff, just like for COVID-19. This is healthcare people. So it's just, so which flu vaccine should be used? Now, age group is 6 to 2 years. You should never give the live vaccine. You must give either 4 or trivalent killed vaccine. Live vaccine is not suitable. Age between 2 to 17 years, you give live vaccine. Age 18 to 64, actually they say 2 to 49 years now. That is the recommendation now. 2 to 49 years, you give live vaccine. Adult, so up to 65, over 50 to 64 now, they say you give again the killed vaccine. And then adult over 65, you have to give, better to give trivalent vaccine, which is called adjuvanted. You have added adjuvant, aluminium. And then they give, because after 65, as I told you, they have what you call immunosenescence, so they don't produce that much of antibody response. So therefore, better to give adjuvanted trivalent influenza vaccine. So commonly reported axillary, you can have local reactions, and then you have sometimes you can get live flu vaccine, you can get nasal congestion, rhinorrhea, reduced appetite, weakness, and headaches. And then these are the things that you can get: myalgia, shivering, fatigue, headaches, low grade fever. Now, this subunit vaccines, that is the new vaccines, actually causes, you can see, very much less side effects, local side effects, as well as fever, much less with subunit vaccine than the previously have split vaccines. So contraindications. Wherever there is a doubt, expert advice should be taken. The children aged 2 years up to 18th birthday, where live flu vaccine cannot be given, it is likely that inactivated vaccine could be given instead. For this, for not only 18 up to 49 years of age, that is what you should do. None of the influenza vaccine should be given to those who had confirmed anaphylactic reaction to the previous dose of the vaccine, confirmed anaphylactic reaction to any component of the vaccine. Now, the live attenuated vaccine should not be given to children who are clinically severely immunodeficient due to conditions of immunosuppressive therapy, leukemias, lymphomas, HIV, cellular immunodeficiencies, high-dose corticosteroid, receiving salicylate therapy. Known to be pregnant, you should never give, again, salicylate, as I told you, because it can cause Reye syndrome. And also severe asthma or very active VC. And also if they are on very high dose of corticosteroids orally, you should not give. Children currently taking high dose of inhaled steroid should only be given live flu. This is an important point. I don't know why, I just try to find out why it is so, but they say if you are going high steroids orally, you should not give live vaccine. But for a pneumonia child who is having asthma, if he's on inhaled steroid, they should be given the live attenuated vaccine. I don't know why, but this is actually the NHS guidelines. Precautions. Again, acutely unwell. Then if you have nasal congestion, and then if you have already given antiviral agents, obviously you can't give the live vaccine then. Egg allergy. This is a very controversial topic, so I thought I will advise, because this our new book is coming in, vaccine book for this year is coming up, I think, on Monday. And there we decided egg allergy is not a contraindication. Now that is what people believe. Most flu vaccines are prepared from flu viruses grown in embryonated hen's egg, and the final vaccine product contains a fairly amount of OLB. But the newer vaccines have very little OLB. Adults with egg allergy can be immunized in any setting using an inactivated flu vaccine with an OLB content less than 0.12 micrograms, that is less OLB. Adults with severe anaphylaxis to egg that has previously required intensive care should be referred to a specialist for immunization in hospital. So therefore, they don't say you should not give. You can still give it, but in a hospital. There is no OLB-free vaccine available in many countries, but it is available now in other countries, which is called recombinant vaccine. It is completely egg-free, protein-free. However, there are low albumin containing vaccines with very low risk of allergy. In children also the same thing. Children with an egg allergy can be safely vaccinated with a live vaccine. And both egg allergy, those with both egg allergy and clinical risk factors that indicate live vaccine then should be offered inactivated flu vaccine with a low albumin content. Children with history of severe anaphylaxis that has previously required intensive care should be referred to a specialist for immunization in hospital. So you see, neither NHS nor the ACIP American guidelines, not in our guidelines also, we now don't, we see that egg allergy is not a contraindication, even though this is being made with egg yolk. Severe asthma, this is an important point, as I told you. Live flu vaccines is not recommended for children and adults with severe asthma or active asthma, those who are currently taking or have been prescribed oral steroid for respiratory diseases in the last 14 days. If you want to give, you have to stop steroids, and after 14 days, then give it. Children currently taking high dose of inhaled steroid, budesonide or equivalent of fluticasone, should only be given a live flu vaccine on the advice of their specialist. Don't ask me why, because I just took it from the NHS. As these children are in a defined flu risk group, those who cannot receive a live vaccine should receive inactivated flu vaccines. Asthma people should be given. So the key messages actually is flu immunization is one of the most effective interventions we can provide to reduce burden and health social care services. It is important to increase flu vaccine uptake in clinical risk groups. Not generally, but at least in clinical risk groups. In Sri Lanka, flu vaccine has not recognized by clinicians as an important vaccine, at least in people of 65 years, simply because we don't know the incidence of influenza in our country. We don't have seasonal, we don't have this winter influenza, but we have seasonal influenza. We have seen during the rainy season, there were plenty of cases coming with influenza, a lot of cases coming with influenza. Influenza with pregnancy is a bad combination, so you have to be vaccinate them. Vaccine of healthcare workers is important, that I just wanted to highlight that. So by preventing influenza through vaccination, secondary infections such as pneumonia also can be prevented. This is the point that I want to say. When you give the influenza vaccine, if you don't get complicated influenza, you don't get pneumonias. So this is more important for COVID-19 at this particular time. I think that's very important. Thank you very much. No time? You can ask the questions later. I don't know, I ask the president.
Shall we go for the other
Yeah,
and then have a conversation? Thank you, sir, for that very informative and very revealing presentation. Sorry for the fact that the Q&A session has to be postponed for the time being. Now, the second item in the agenda in the CPD activities management of goiter by Dr. Thanga Samarasekara. Is MBBS, MD Colombo, MRCP and MRCP London, MRCP, and specialist certificate in diabetes and endocrinology UK. Work experience, consultant endocrinologist, and of course international training fellow from University College in London. And his professional qualifications include MBBS from Colombo 2012 and MRCP and MRCP Royal College of UK and London, MRCP Royal College Edinburgh, and specialty certificate, and also MBBS in 2005. May I call Dr. Thanga Samarasekara to make the presentation?
Thank you for those kind words of introduction. Good evening, ladies and gentlemen. And I'm standing between you and your dinner. Fortunately, I have a simple topic, simple but interesting topic. So I think we can pass time without even noticing. And I'm honored to have one of my teachers in the audience, sir. And I would like to thank Samira and the team organizing this event. So today I'm going to discuss management of goiter. So you may wonder why a physician is going to discuss a surgeon's topic. So shall we have a consensus? If you have a goiter and if you want to refer, are you going to refer to a physician or a surgeon? Surgeons? No one. So my job is done. I don't have to do the lecture. I came here to get people to refer patients with goiter for the physicians actually. So, point. Takes time to get the hang of it. Help? Oh, okay. So many years ago, when we encounter a patient with a goiter, usually we end up sending the patient to the surgeon, and off in their neck, they will get a surgery. The reason of this is the available scientific evidence we had at that time, and the available facilities, the facility to do the scans, the thyroid functions, those were limited. But now, of course, the times have changed. Science has advanced. Now we have a better understanding of the natural history of the goiter. We have better facilities, and now our countries, middle-income countries, not a third-world country anymore. And we have good roads, so patients can travel in between cities. They can come to big hospitals and get the workup done. So things have changed. So whom to send the patient, I have already warned it since. Outline of this lecture: what is a goiter, the different types of goiters, the workup, sinister features that we have to keep an eye on, and the follow-up. So we'll start with the case. We have this young lady this 20-year-old, comes to the clinic with a thyroid swelling. She says, well, I have a thyroid swelling. She's worried whether this will get bigger and she will end up with surgery. And her mother, who accompanied her, is worried whether this could be cancer, whether her daughter will end up having a cancer because one of her co-workers had a similar lump, had the surgery, and turns out to be cancer. So how do we handle this case? So again, question, how do your patients present? Are you seeing patients with goiters in your practice? Yes. So how do they present? These days, they usually come complaining of a neck lump, or others have noticed your neck, there's something wrong there, there's a lump. Why don't you get it checked with the doctor? Could be cancer. And special teachers, they come with hoarse voice, although not related to it, because of the hoarse voice, they will look at the neck, then they will notice the lump, and they might come. Of course, these days, I am seeing less teachers because they are resting at homes. They are not abusing their voice, but they come with different complaint, high blood sugar. And people might come with throat pain. It could be due to pharyngitis, but the pain, because of the pain, they might notice a lump, which has been there for a long time. Or it could be due to thyroiditis, subacute thyroiditis, could be a thyroid cyst, which has been bled inside. Or it could be noticed by you, us actually. Patient comes with knee pain. While looking at the knee, we look at the neck, then we notice the lump. There's a lump in your neck. Have you noticed? No, I don't. I'm feeling fine. Then we do the workup. Or sometimes it's a bystander. Someone accompanied the patient. When we are chatting, we notice the lump. So it's like that now. So what is clinical presentation? Most of the time it's asymptomatic patients. And they might come with thyroid dysfunction, features of hypothyroidism or hyperthyroidism. And later in life, with large people with large goiters, they might come with obstructive features like shortness of breath on exertion, of stridor, wheezing, especially this wheeze is coming from the upper airways, not the lower airways like in bronchial asthma. And they can come with hoarse voice. And sometimes they can come with pain in their throat. I'm to refresh your memory to anatomy. Thyroid gland, of course, is located in your neck, in the trachea, and it's a butterfly-shaped gland with two lobes connected with the isthmus. Just want to highlight the fact that esophagus is behind the trachea. So if your patient comes as tiny goiter complaining of dysphagia, it's unlikely that it's a causing the dysphagia, because to cause the dysphagia, the gland has to enlarge, go down and posteriorly and compressing the trachea, and then it has to compress the esophagus. So you have to think of other differential diagnosis, especially they complain of dysphagia with a small goiter. What is a goiter? It's an abnormal growth of the thyroid gland. It can be diffuse or it can be nodular. The nodule could be one single nodule, could be multiple nodules. And the thyroid hormone production can be normal, it could be high, it could be low. And if you are going, there's a list of causes for the goiter, but if you look at the common causes, it's usually in the younger population, it's Hashimoto's thyroiditis, and in the older population, it's multinodular goiter. And in between that, you get a large number of causes. Iron deficiency goiter worldwide, it's the commonest cause of goiter, but in Sri Lanka, we don't see iron deficiency goiter anymore. And in the next slide, I will explain why. And in certain parts of the world, it could be due to ingestion of goitrogens, not common in Sri Lanka. And thyroid infiltrative diseases, although rare, they are very common, very interesting group of diseases. When you diagnose one, it's actually a big incident. And patients with hyperthyroidism, they can come with Graves' disease, which usually a diffuse goiter. And then you have the adenomas and the carcinomas. So this is a paper done by Dr. Renuka Jajissa and her team, is Sri Lanka ID sufficient? In 1986, there was a national survey done, and almost 1 in 5 adults in Sri Lanka had a goiter at that time. So in 1995, the government decided, okay, we are going to do a universal salt iodization. And 10 years later, they looked at the result, and very happy to say that the incident has come down from 20 to 3.8. So 4 people in 100, from 20 people in 100, the incidence of the goiter has come down, and everyone is iodine sufficient now. And again, in 2010, they have revisited the study, and they have looked at again the parameters, and we are maintaining our iodine level. So it's a big success for our country. And I know most of our senior consultants and the senior practitioners have contributed this as well. Goiter workup is simple. So our aim is to assess the thyroid function, which is simple, clinical history, examination, and the thyroid functions. Then look for the underlying cause, which could be a bit tricky. Then rule out malignancy, which is the most important thing, and plan management. To plan the management, you need to know the goiter size and the presence of nodules, because that will determine the prognosis, and presence of obstructive and compressive features, because the surgeon is waiting, and presence of tracheal narrowing. In the clinical history, you would look at the duration of the goiter. If it is a longer duration goiter, then chances of malignancy are less likely. And if it is shorter duration, elderly person, rapid growth, then could be a malignancy. Then presence of hyper and hypothyroid features, obstructive features, pain, fever, feeling ill, the B symptoms, which could indicate a lymphoma, and family history of thyroid illness, because thyroid illness can run in families. Diseases like Hashimoto's thyroiditis, Graves' disease, and sometimes goiter, the endemic goiter. Then some drugs like lithium and amiodarone can cause thyroid problems. And most importantly, patients and his or her family's concerns. Why they came with this problem? Are they worried about a cancer? Because if you ask it directly, most of the time they will tell, yes, I'm worried whether this is a cancer, because you need to address that concern as well. And in the examination, in general examination, we will look at the hyper and hypothyroid features, remember hand tremors, tachycardia. In hyperthyroid patients, you get sweaty hands, warm sweaty hands. In hypothyroid patients, you get dry cold hands, and other relevant features like generalized lymphadenopathy and vitiligo in autoimmune diseases. In the eyes, you look for Graves' orbitopathy, because if you see Graves' orbitopathy, you don't need to do further antibody levels or anything like that. You know the diagnosis. And in the neck, you do a careful examination of the goiter, whether it's a diffuse or nodular goiter, then intestinal extension, features of obstruction, Femberton signs, cervical lymph nodes. And in a patient with diffuse goiter, you look for the thyroid fluid. Of course, these are pre-COVID era things. Now the things have changed. So to do this examination, you have to spend like 5 minutes with the patient. So close contact. So I don't know, in current situation, are you going to risk it? And wearing all this mask and everything, going close to the patient. So you might end up doing the scan straight away. Investigations, of course, thyroid functions. I'm going to do TSH, or I'm going to do other thyroid functions as well, T4 and T3. And this ultrasound scan, when I'm going to do the scan, FNA, are you going to do FNA in everyone, or are you going to do in selected group? If you're doing the FNA, is it a guided one or is it an unguided one? These are the questions we need to answer. And other tests like thyroid peroxide antibodies, TSH receptor antibody levels, radioactive uptake scans, and other advanced investigations for imaging. Thyroid function tests. So all patients with goiter, you need to do a TSH. That's basic. Everyone has to get a TSH done. And if they are hyperthyroid clinically, you can do a T4 as well. And if it is a multinodular goiter, apart from doing TSH and T4, you can do a T3 level as well, because some multinodular goiters, they are T3 toxic. They have T3 toxicosis. So if you do the T4 TSH will be suppressed. T4 could be normal or low. But if you do the patient is clinically toxic, if you do the T3, it will be high. But the problem is T3 is a bit of a difficult investigation to do if you need to have a good lab, reliable lab, because I have seen even in the best labs, they sometimes miss up the results. We get wrong values. Then I have to send the blood again to the MRI, the reference lab, and get the test done again. And sometimes the results are totally different. This is just to highlight. So a good radiologist will sit with the patient, takes their time, and if there's a nodule, they will look at the features of the nodules carefully to categorize whether it's high risk of malignancy, low risk of malignancy, and the intermediate risk category. So there are these other features. So when you get the report, you can go through the characteristics of the nodule and you can know for yourself, okay, this is what we are dealing with. This is to complicate the matters because there are different societies, so everyone has to have their own thing, otherwise they are not special, right? So each country they have their own thing, but end of the day it's the same. It's high risk, intermediate risk, and the low risk, just by ultrasound scan. So if you have a good radiologist, ultrasound scan will give you the answer whether it's cancer, high risk of cancer, or low risk of cancer. If it is low risk of cancer, you can reassure your patients, and that's it. If it is high risk of cancer, of course, you need to fast track everything and do the full workup. And the intermediate risk category is the problematic one. That, of course, you need to send to the specialist to work out, because it's usually a multidisciplinary team approach. You need to talk with the histopathologist, radiologist, surgeon, and the physician. When to do the FNA? There are no hard and fast rules. It's a risk continuum. So in the green zone, you have this benign looking lesion. You wouldn't do a FNA on that, because FNA is an invasive test. Although it's simple needle prick, it hurts. If you ask the patient, it really hurts. And most of the time, they don't want to do a second test. So you don't do it unless it is really indicated. So purely cystic lesions, benign looking solid lesions, you're not going to do FNA. But on the other hand, if there are high risk features for malignancy, yes, you will do the FNA as soon as possible and get it reported from a good histopathologist. And again, there are indeterminate or the middle zone. Those people might have it, you might do, you might not do. So how FNA as a test? It's a good test. It's a decent, it has decent sensitivity. Good, I would say good specificity. But I would like to turn your attention to the false negative rate, even at a base center. Even at the base center, there's a 0.5% chance that you might miss a cancer. Base centers, but in Sri Lanka, of course, I don't know. Number may be high. But it's an invasive test, yes, but it's available everywhere. And when you are doing the FNA, always go for a guided FNA. Don't do unguided FNA because it's useless, because there will be few nodules. The biggest nodule may not be the malignancy. It could be another small nodule. So always ask your radiologist to look at the nodules, take the biopsy from the suspicious one. And the FNAC report, there are two countries want to have their say on the thyroid. So there's thyroid classification, which we are familiar with. Then you have Bethesda. Again, it's a simple. You have high risk, that's malignancy confirmed, almost confirmed. Then you have low risk, that's benign. Then you have the indeterminate area. What is the risk of cancer? If the patient asks, okay, doctor, I have this lump in my neck, what is the risk of cancer? So it's around 5%. And thyroid cancers, they have the best prognosis among cancers. So you can always reassure the patient. So this is a busy slide. just want to highlight the FNAC result and the suggested action. This is a nodular void, okay? And this FNA was done in a guided manner. And if it is a benign one, just your left hand side, just follow up. You're not going to do refer the patient to the surgeon or take out. But if it is a malignant one, you want to fast track, send the patient to the surgeon and get a thyroidectomy done and get the histology. The in between ones, that's where the interesting thing happens. Then you have to have an MDT center where I work in UK. We have, every Thursday we have a meeting where the histopathologist, the radiologist, surgeon, and the physician come. We discuss. Okay, what I'm going to do with the patient. Then we come to a management plan. Then we take the patient in. Then we discuss with the team. When the patient can ask the questions, then we can clarify, because there are no hard and fast rules there. Because what we want to do is best for the patient, and it depends on each individual case. So if the facilities are available, you can do molecular analysis of the nodule, then decide on whether you are going to do a lobectomy or a total thyroidectomy, depending on the risk factors. From the basic point of view, these are treatment options. You can just observe without doing anything. This is the most case, in most situations is the case. Or you can give thyroxine suppressive therapy. This is a very controversial area. That this used to be the practice, if I remember it correct, nodular goiters. We used to give thyroxine to keep TSH below the normal range. Objective is keep the TSH below normal level, so the nodules will either shrink or they won't get at least enlarged. So people who are supporting this, what they say is, okay, there is evidence. Yes, I also agree. There is evidence. There are papers that shows if we give thyroxine in euthyroid nodular goiter, the TSH is normal in this patient. Patient doesn't have any features of hypothyroidism. We give thyroxine and keep the TSH below the normal level. Time, there's a shrinkage of the nodule, or at least the nodule won't get enlarged. But that's only a subset of patients. There is another subset of patients, despite the treatment, they will have the enlargement of the nodule and the natural history will progress. On the other hand, we are giving thyroxine to a euthyroid patient. So the patient is in like a iatrogenic hyperthyroid state. So that could lead to reduced bone mineral density and can cause atrial fibrillation. Those are the risk factors. So I would leave it open to whether to give or not the thyroxine suppressive therapy. I will value your input as well. Then we can do radioactive iodine therapy, then surgery, lobectomy, and the total thyroidectomy, again, controversial topics. And new ones are the ethanol injection for the cystic nodules done by the radiologist. This is the natural history of simple goiter. Simple goiter means the patient, all the tests are normal, right? Antibodies are negative, you don't have any other possible etiology like radiation. In the younger group, that we commonly see, teenagers, they come with a diffuse goiter. If you keep observing these patients with time, when they reach the middle age, they will start developing nodules. Then you keep observing, by the time they reach 60, 65, the nodules become more prominent. If you look at the biochemistry, thyroid functions are normal initially during their teenage years, but as time progresses, the TSH starts to go down. And when they reach their 60s, the nodules are hyperfunctioning. They will produce thyroxine. So the T4 and T3 will go up and the TSH will be undetectable at that time. And tracheal compression, when they goiter is enlarged, they will have tracheal compression. So these kind of patients, best case would be to just observe in the initial phase. Once they develop symptoms or the biochemical hyperthyroidism, you can think of treating them. By doing that, you would avoid surgery at a younger age and you would avoid unnecessary treatment. But when the time is right, then you can proceed with either radioactive therapy, antithyroid medications, or even surgery if it is indicated. So what is the next step? From the primary care level, if it's a euthyroid patient, diffuse goiter, just observe, reassure, follow up. If the patient is hypothyroid, diffuse goiter, start levothyroxine treatment straight away. You don't have to refer and monitor and follow up. But if the patient is hyperthyroid, just think what is the diagnosis. You can start beta blockers. The patient has asthma, you can do calcium channel blockers to control the heart rate. And if you are certain about the diagnosis, okay, this is Graves' disease, this is toxic maternal goiter, then you can start antithyroid medications like thimerosal. Then you need to refer for further investigations. If it is a nodular goiter, it's better to refer because you need to do the scan, the FNA, then depending on that, you do special tests and then management. So it's better to refer the nodular goiter. So take home message, goiters are common. So it's our job to make the patient less anxious because if you ask the question, they are worried about cancer. That's what they think. And do the clinical evaluation, the thyroid function is available everywhere, and the scan. And if you're doing the FNA, always do a guided FNA. And start treatment, don't wait, start treatment and refer as appropriate. And there is no suppressive place of thyroxine suppressive therapy for the euthyroid diffuse goiter. Okay, euthyroid diffuse goiter. Don't start thyroxine, but euthyroid nodular goiter, I would leave it open. And not all goiters need to be taken out. Patient doesn't having goiter doesn't mean they have to undergo the knife, but when they do, they do. So when there are indications, don't hesitate. Convince the patient and refer for surgery. Thank you. Any questions later?
Thank you, Dr. Dahanga. I think we are behind the schedule, but I think it's a pity if you don't have a Q&A session in such a
Dharanga, thank you very much for the short but comprehensive lecture. Just a small point, you showed a photograph of the goiter being examined from France.
Yes.
When we were having pre-clinical classes in 1963 from Mr. CPD Fonseca, he said that at the exam, he will leave a chair against the wall, and unless you move the chair forward and examine the patient from behind, he will fail you. And also at that time, keyboard erosion was very common. And the statistical message was given, and history taking, one had to ask whether the patient is on PAS. Otherwise, you fail. That's what I read was CPD concept. Another small matter, Wikipedia spells goiter Goitre, and the IMPA has spelled goiter Goitre, not Goiter. Just a small matter. And about HT, quite right pointed out during the Asian flu epidemic in the 1970 that when the material was examined later on, they found that it was due to bacterial pneumonia, and the pathogen was Streptococcus pneumoniae, and that is the one that killed. And now, of course, vaccines are available not only for influenza but for the pneumococcus also. And the current recommendation in most countries is that if you are over 65, you should be taking the influenza vaccine every year and take both the conjugated as well as the polysaccharide pneumococcal vaccine that is recommended for over 65. And especially now the COVID days, I think one should be taking the pneumococcal vaccine for those who are over 65. That's all. Thank you.
There's a small question for Dr. Tang. You, in one of your slides, you mentioned the simple goiters in the natural history will go on to the nodular goiter and multinodular goiter. Does it always happen like that? There's no remission of simple goiter at all?
There is a percentage that goes to remission.
What is that percentage? Because our clinical experience is sometimes when you follow up these patients that the remission is probably, I don't know, it may be biased also, but then there is a group definitely who remits.
Yes, but we don't know what are the treatment. You were saying Scotland, we are more towards the American side, that's why
The spell is Goiter is American, GITR is English.
And now also they
Yeah, there's a question. Mike.
Dr. Steve now what is the influenza vaccine we have in Sri Lanka? Is it, have we got the right temperature? But I
No,
think we have only the virus.
we have evidence and published both.
We don't have the right virus. And one secondly, why is it not accepted now in Germany? We try to motivate the patient to take influenza, but really
Very good question. In the first place, we don't know how many cases we have because people with influenza, now even if you suspect influenza, I just asked people at LRH, they never do influenza. This is the influenza, it's only
Yeah, that is the whole problem when it comes to these chronic respiratory diseases also, because the clinical diagnosis is not made. Clinical diagnosis is not made, but not a laboratory diagnosis. So because of that, there's a hesitation to cover up them with the vaccine.
and already we get the vaccine very late. Now
Yeah.
we get the vaccine after somewhere in April and May.
And actually, we are now our vaccine forum is trying to get food vaccines. And that we have some.
Now, he referred to influenza causing maternal deaths few years ago. Now, I sit on this advisory committee on communicable diseases, we are the national advisory body. And there was a lot of discussion whether the influenza vaccine should be given to pregnant mothers. And a committee was appointed with obstetricians, virologists, community physicians, etc. And the final verdict was that it is too expensive to include it in the national schedule to give it to all pregnant mothers. But it is not a very costly vaccine. And GPs are recommended to, if the patient can afford it, to prescribe it to a pregnant mother.
So 1,000 rupees.
Yes.
Yeah, it's not that big.
So there's another small question regarding these vaccines, particularly now that the mRNA and DNA vaccines are coming up. Does these vaccines, when you say prevent the illness, it's a little bit of a global thing of, I mean, you think that it prevents it, but then how about the complication rates? How about the transmissibility of the infection from one person to another? Are these things covered by the vaccine, or are we not sure about? Not necessarily COVID-19, but
COVID-19, the vaccine what we are getting is the AstraZeneca vaccine, which is from India. That vaccine doesn't give that much of protection like Pfizer. But however, the vaccine gives the protection if you give the vaccine after 3 months, not 28 days. 28 days is what they have discussed earlier, but now they say 3 months. Then the protection goes up to about 84%. But the beauty was that what they found was that even the people who get COVID-19 after giving the vaccine, 21 days after giving the vaccine, they don't die. Even the extreme weak. So mortality reduction is almost 100%. So that is what the vaccine is for. Even you get it, if you don't die, that is what the vaccine is for. So that is what we
yeah, other than the transmission.
transmission, of course, these vaccines does not do it that much of transmission. They have some form of what we call herd immunity. Every vaccine causes there is some form of herd immunity. If you vaccinate certain proportion of the population. Now, for example, all the other vaccines like polio vaccine or whatever, if you vaccinate about 75 to 80% of the population, that there is almost 100% herd immunity. Whereas COVID-19, they say much less, they say 60%. But with different people, you don't know exactly what will the actual thing.
Another you raised an important issue. Now, today's paper is full of it. Because the age groups that have been targeted for the vaccine. Now, some decisions have been made, we don't know by who, to vaccinate between 30 and 60 years to prevent transmission. Now, that is not she recommended. The advisor recommended, did not recommend it at all. And for a short time, in some government areas, they were giving all the visitors between 30 and 60, but not giving it to over 60. It's utterly stupid. Because the prime objective should be to prevent deaths. And you prevent deaths by vaccinating those over 60 and those with comorbidities.
To say that this is the only country in the world where they are giving the vaccine for the first time for 30 years. Not for
You mean?
A country like Norway.
Okay, I think as time is also passing by, I think before I invite our secretary to propose a vote of thanks as a mark of appreciation of our resource persons, I just want to present them with a certificate of being a resource person for IMPA. Call upon Dr. Tanaka Samaraseka as a mark of appreciation for being a resource person for IMPA. Thank you so much. I call upon the secretary to propose the vote of thanks.
Thank you, Ananda, for with the present task of proposing the vote of thanks. Ladies and gentlemen, at the outset, let me extend our grateful thanks to the two speakers, Dr. H.T. Vikramasinghe, Senior Consultant Pediatrician, and Dr. Taranga Samaraseka, Consultant Endocrinologist, for sharing their expertise and giving us a very valuable presentations. Let me thank all of you members joining us this evening at the OPA, and also those who joined us online for today's Country Medical Education Program. A very special word of thanks to our worthy sponsors who made this event possible by generous sponsorship, Abbott Laboratories. We thank them very much. I also would like to inform you that all our recent presentations are uploaded in our website. You would access them, and even today's presentation will be uploaded in a few days' time. So let me thank again all of you again, and invite all of you for the fellowship and dinner, and wish you a pleasant evening. Thank you.